Web Interface support call. During today's webinar, CMS will provide an overview of 2019 CMS Web Interface quality reporting for MIPS groups and ACOs. And after the webinar, CMS will take as many questions as time allows. So now I'll turn it over to Reina Justy to begin.
Thank you. Welcome, everyone, and thank you for joining us today as ACOs and MIPS group practices prepare for CMS Web Interface quality reporting. I'm Reina Justy from CMS, and also joining me on the call today are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation was current at the time it was published, but please be sure that you're using the source documents and links that are provided throughout the presentation, and please stay tuned to any communication from the Quality Payment Program, Medicare Shared Savings Program, ACO, or Next Generation ACO model regarding any updated information. Next slide, please. The recording, slides, and transcript for the February 26th call are now available on the Quality Payment Program webinar library. Next slide, please. The submission period for the CMS Web Interface aligns with other submission types for 2019 opening on January 2nd, 2020 and closing at 8 p.m. Eastern Daylight Time on March 31st, 2020. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website, which is circled here. We encourage you to submit your 2019 MIPS performance period data in advance of the submission deadline of March 31st. Early submission will provide you with time to receive assistance from the QPP Service Center, have other CMS Approved Reason requests reviewed, and complete the CMS Web Interface reporting requirements. Next slide, please. As you may know, today is part of a series of Web Interface support calls held weekly throughout the data submission period. The next support call will be held next Wednesday, March 18th, 2020, from 1 to 2 p.m. Eastern Daylight Time. Topics will include measure FAQs on confirming a diagnosis, DM2, hemoglobin A1C poor control measure, MH1, depression remission at 12 months, PREF12, screening for depression and follow-up plan. Additional topics may also be added prior to the support call. Next slide, please. The other CMS Approved Reason skip requests must be submitted through the CMS Web Interface. This is a way to skip a patient attributed to a measure during denominator confirmation. The CMS Approved Reason is reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. Patients for whom a CMS Approved Reason is selected will be skipped, and another patient must be reported in their place for the measure if available. We encourage you to submit a 2019 CMS Approved Reason as soon as possible and no later than Friday, March 20th. Submitting after March 20th may cause your request to not be processed prior to the close of submission. Next slide, please. The 2019 CMS Web Interface API is available all year for testing in the developer preview environment. You can review the resources listed on this slide for more information. Next slide, please. And now we'll go over medical record documentation, frequently asked questions. Next slide. The first question is, are we allowed to go outside of the ACO participants to find medical record data? The answer is yes. CMS encourages ACOs to obtain medical records for their assigned and sample patients. This includes collaborating with physicians and or other clinic staff, both inside and outside the ACO, including but not limited to the NPIs provided in the CMS Web Interface, as well as facilities both inside and outside the ACO, with such collaboration attempts being repeated throughout the course of the data collection period if needed. Note that the data entered into the CMS Web Interface should never reflect services provided after the end of the performance year, that is December 31st, 2019. Next slide, please. Can a MIPS group add documentation to the EMR in 2020 for performance year 2019? For instance, if a colonoscopy is not found in the EMR during the data collection period for performance year 2019, and staff reach out to a performing facility to get a copy and it is scanned in EMR in 2020, can that be counted for performance year 2019? The QPP measures should be completed based on information that is available in the medical record prior to the end of the measurement period. There could be instances where the procedure encounter occurred towards the end of the measurement year and the medical record was updated early in 2020, but these instances should not be the norm. It would be more beneficial to the patient if coordination of care coincided with the patient's encounters as opposed to collecting missing information afterwards for purpose of quality reporting. The submission period is not intended to be a time for filling in missing information, which was only identified due to the patient being attributed to a measure for performance purposes. The measures are not intended to interfere with clinical practices. If a measure calls for information that is not available, then the provider may not meet the intent of the measure. Next slide, please. And now I'll pass it off to Angie Stevenson to go over frequently asked measure questions.
Hi, everyone. This is Angie from the PIMS team. The frequently asked questions we'll be reviewing today are for the HTN2 controlling high blood pressure web interface measure. Next slide, please. First question is HTN2. What should be reported if the most recent blood pressure value is documented incorrectly? For example, 18/72. In the event that the most recent blood pressure value is documented incorrectly, move to the next most recent valid blood pressure documented within the medical record. Question 2, do we include blood pressures taken from urgent care? Yes, urgent care is an outpatient setting, and the HTN coding document contains urgent care denominator codes for the measure. Number 3, are blood pressure readings from an inpatient setting or emergency department acceptable? Yes, although the measure is intended to be outpatient, blood pressure readings from any clinical setting are acceptable when reporting the numerator. It would be appropriate to move to the next most recent blood pressure if the most recent blood pressure is from an inpatient setting or ED and is not within normal parameters. Next slide, please. Next question is, if the patient has a visit during the measurement year with a billing code of I-10 or essential hypertension, would this count for confirming the diagnosis? Answer is no. Coding alone is not sufficient documentation to confirm the diagnosis. There must be medical record documentation to support that the patient has essential hypertension. And the last question is, if there is medical record documentation of essential hypertension during the year prior to the measurement period, but the diagnosis is not found during the measurement period, can we confirm the diagnosis? For denominator confirmation, the diagnosis cannot end prior to the start of the measurement period. The medical record documentation should support that the patient has a documented diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period, but does not end before the start of the measurement period. Thanks, everyone. And now I'll turn it back over to Reina at CMS.
Thank you, Angie. Next, we'll go over available resources and where you can go for help. Next slide, please. Please note the 2019 materials providing information on the MIPS quality performance category are available on the Quality Payment Program Resource Library. We encourage reviewing these resources if you have questions on quality requirements and measures. We will continue to communicate any future postings in upcoming support calls. Additionally, the help and support page on the QPP website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. The QPP webinar library also contains recordings, slides, and transcripts for past QPP webinars, including the recent 2019 CMS Web Interface user demonstration held in November and the CMS Web Interface kickoff call held last December. The recording, slides, and transcripts for the January and February support calls are also available on the library. Please note that it may take 1 to 2 weeks to post the presentations to the library following a webinar. Next slide, please. Next slide. This slide contains links to resources available for Medicare Shared Savings Program, ACOs, and Next Generation ACO model. We encourage you to review the materials available here and sign up to each newsletter for more information. Next slide, please. And if you need additional assistance, please refer to the contact information listed on the slide. Next slide, please. Okay, and now just before we head into the Q&A portion of this call, if you're interested in providing feedback and collaborating with CMS on the quality payment program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qppuserresearch@cms.hhs.gov. Next slide, please. And now I will hand it over to Ketchum to begin the Q&A session.
Okay, great. Thank you for that. So now we'll start the Q&A portion of the webinar. If you'd like to ask questions, you may do so by submitting via the questions tab on your screen for us to read out loud. Or you can raise your hand. That's the green hand icon on your go-to menu, and we can unmute your line. So your first question concerns PREV 13. And it asks, for the PREV 13 ACO measure, there are 3 population groups. Are each of the 3 numerators and denominators combined for the creation of one rate to be submitted and scored?
This is Deb from the PIMS team. So the stratification of the patient populations are based on risk factors, but the outcome is the same, and that is whether or not the patient is on a statin. So for this particular measure, what happens is you're going to look through each of the different denominator criteria in order. All of those patients that are considered eligible for the measure are then reported whether they're compliant or not compliant for statin therapy. So it's just the one statin therapy numerator compliance for all 3 of those risk factors. Thank you.
Great, thank you. All right, next, for the MH1 measure, if the patient diagnosis of depression due to dementia, does this still count?
Hi, this is Katie. So for MH1, it does require a specific diagnosis of major depression or dysthymia. So in this case, no, the diagnosis would not count if that's all that's documented in the medical record. Thank you.
Great, thank you. All right, your next question also concerns MH1, and it asks, if the patient diagnosis says depression due to head injury and the code in the patient chart is S32.9, which is included in the coding document, does that count even though major depression or dysthymia are not written in the chart?
Hi, this is Katie again. So for all web interface measures, the coding documents are available for reference. However, coding alone is not appropriate documentation. So although that code is present in the coding document, the diagnosis doesn't match. So in this case, we would encourage you to review the medical record for any other confirmation of major depression or dysthymia. Thank you.
Great, thank you. All right, also on MH1, what time frame should be used for the measurement assessment period if there is no PHQ-9 administered? This is in reference to determining if there is a denominator exclusion or should the denominator exclusion be applied after determining if there is an initial PHQ-9 screening?
So if there's no initial PHQ-9 screening, that would mean the patient is not eligible to be confirmed in the denominator. So that measure assessment period would not even be initiated because it's triggered by the appropriate diagnosis associated with the date there's a PHQ-9 greater than 9. So if you cannot confirm that the patient had that initial PHQ-9, then the patient wouldn't be denominator eligible in the first place and you wouldn't confirm them. So any sort of denominator exceptions or exclusions wouldn't apply in this case. If you need additional information, I would encourage you to submit a question to qpp@cms.hhs.gov and we can work through that with you a little bit closer. Thank you.
All right, thanks for that. Okay, we have a question on the phone line. This is from Amanda Balgobin. So Amanda, we've unmuted your line and you can go ahead.
Hi, I had a question about the hypertension slides that you guys just presented. It stated that ED and inpatient blood pressures are acceptable, but maybe my interpretation was incorrect by the CMS measure specifications. It says in the guidance in reference to the numerated to element, only blood pressure readings performed by a clinician in the provider's office are acceptable for the numerator compliance with this measure. So I'm not really understanding where the ED and inpatient component came into place.
Hi, so this is Katie from the PIMS team. So this is actually clarification that we worked through. You're correct that the language in the specifications in this case doesn't match exactly. So although the measure is intended to be outpatient, blood pressures from any clinical setting are acceptable when reporting the numerator. So in this case, if your most recent blood pressure is in control and is found in an ED or inpatient setting, you can use it. If it's not within normal parameters, it would be appropriate to move to the next most recent. So it's kind of a little bit open-ended. You can use blood pressures from those settings, but you're not obligated to. And that's just simply because it's not specifically defined within the numerator. So that's the reason for that clarification. Does that answer your question?
Okay, so you're pretty much, just to make sure that I understood that. So if I reviewed my list and I found that the most recent blood pressures that I have documented are out of range, if I was to find an inpatient or an ED BP that was in range, I could use that, or has to be the most recent?
So it has to be the most recent, where if the most recent is within the ED or inpatient setting and it's not within normal parameters, then it would be acceptable to move to the next most recent.
Okay, sounds good. All right, thank you very much.
You're welcome.
Okay, great. All right, your next question concerns DM2, and it asks, can you please clarify what is meant by history of diabetes versus active diagnosis of diabetes? What if a patient was diagnosed in 2010? Would that still count?
This is Deb. If the patient was diagnosed in 2010 and the diabetes diagnosis is still considered active in 2018 or 2019, then that patient would be confirmed. If that patient was diagnosed in 2010 and they're not considered an active diagnosis in 2018 or 2019, then that patient would not be confirmed. Thank you.
Great, thank you. All right, next, does gait normal meet the measure for CARE 2?
Hi, this is Olga from the PIMS team. If you have documentation of an assessment of gait or balance within the medical record during the measurement period, that would meet the intent of the measure. For CARE 2, you would need to have documentation in the medical record of a fall risk screening, and that again can include the patient's history of falls, a described fall, a note stating no falls, or as mentioned, an assessment of gait or balance during the measurement period. Thanks.
Great, thank you. All right, next we have another question on the phone line from Reina Kaplan. So Reina, we've unmuted your line and you may go ahead.
Hi, just to follow up on the hypertension, I'm wondering if the same criteria still stands for 2020, that blood pressure readings from any clinical setting will be acceptable for reporting.
Hi, so this is Katie from the PIMS team. I know for purposes of this call, we would like to stick to 2019 measure specification questions, but the 2020 specifications are posted on the CMS website. So we would encourage you to access the resource library for the 2020 Web Interface measure specifications. There's also associated release notes and coding change documents out there. So I would encourage you to take a look at those. And then if you have any questions, please submit them to qpp@cms.hhs.gov. Thank you.
Okay, great, thank you. All right, your next question asks, can hypertension mentioned in a chart note qualify someone for a denominator, or does an ICD-10 code need to be documented to include patient in the denominator?
Can you please repeat that question?
Of course. It asks, can hypertension that is mentioned in a chart note qualify someone for a denominator, or would an ICD-10 code need to be documented to include the patient, therefore, in the denominator?
Thank you. So for hypertension 2, again, you would need that confirmation of essential hypertension. And just to reiterate, so the coding documents associated with the measure specifications are considered all-inclusive when mapping to an EHR. They can be used as a guide for reporting if you're doing manual abstraction. But in either case, your medical record documentation needs to support the information that's submitted. So while coding alone cannot be used to confirm a diagnosis or any of the other pieces of reporting within the measure specification, your medical record documentation must support that. So again, in this case, you would need to confirm that it was an appropriate diagnosis of essential hypertension within the time frame specified. Thank you.
Great, thank you. All right, your next question is from the phone line. It's from Rachael Grassworth. So Rachael, we've unmuted your line and you may go ahead.
Hi, so I just want some clarity around the statin measure in regard to Strata 1 and Strata 3. So for Strata 1, it states that, and I'm going to pull up the spec here. So it states that the patient has to be over 21 years at the beginning of the measurement period with clinical ASCVD diagnosis. So for the diagnosis portion of that, do they have to have the diagnosis assessed during the measurement period, or can we use historical diagnosis to determine if the patient is denominator eligible for that strata?
All right, I am looking at that within also the specifications down further within the denominator confirmation, population 1, so on page 10. And the information there is to determine if the patient had a diagnosis of ASCVD, active or history of, at any time up through the last day of the measurement period.
Okay. So it can be any time previous to the measurement period as well?
Yes.
Okay, perfect. And I'm going to actually scroll down to population 3. And my same question stands for population 3 with type 1 or type 2 diabetes.
So the diabetes diagnosis is defined as any history of diabetes prior to or during the measurement period, and that is on page 12 within that guidance box, at the bottom of page 12.
All right, thank you very much.
You're welcome. Have a good day.
All right, your next question concerns PREV 13, and it says that the PREV coding document has the code E78.0 and 78.01 for pure and familial hypercholesterolemia. If the code E78 is listed, but the medical record documentation describes it as just hypercholesterolemia, would the fact that the code is listed qualify it for the denominator?
So this is Deb. What you would want to make sure of is, first of all, that the coding that you're referencing is in the coding document, because you're confirming that a patient is qualified for this measure when you confirm that diagnosis. And by doing that, you're kind of stating that you should be able to find statin therapy or a reason statin therapy was not provided. That being said, if you are able to find one of the appropriate codes to confirm diagnosis, and you are able to find hypercholesterolemia documented in the medical record, the combination of those two things could be used for confirmation. If you have any questions as to whether or not that patient really should be held accountable to statin therapy, you're not sure if that diagnosis should be confirmed, it would be best to kind of go back to the clinician to confirm that what you're seeing is in fact confirmation of that diagnosis. But again, if you can kind of, much like the MH1 measure with confirming an appropriate code with documentation of depression, if you're able to confirm an appropriate diagnosis code for PREV 13 along with hypercholesterolemia, those two together should be acceptable. And the reason why is that your coding is confirming the pure or familial. The hypercholesterolemia that you were finding documented in the medical record is more than likely just a quick way of writing it, much like instead of a clinician writing major depression, they write depression, but they have the appropriate code for major depression. Thank you.
Great, thank you. All right, next, for non-fee-for-service Medicare, select this option if the patient was enrolled in non-fee-for-service Medicare at any time during the measurement period, i.e. commercial payers, Medicare Advantage, HMOs, etc. If a patient has a commercial payer that started on July 1st, 2018, what date should we put in the effective date?
Hi, this is Angie from PIMS. The patient confirmation section in the measure specification will provide you this information. You would enter the date the patient became ineligible. If you're not sure of the date's unknown of when they became not qualified for the sample, then you can enter the last date of the measurement period, for example, 12/31/2019. Thank you.
Great, thank you. All right, your next question is in response to an answer that was previously given for MH1 regarding diagnosis confirmation when there's no major or dysthymia noted. But it asks, but the code was present from the coding document F32.9, totally contradicts what the specifications say and what prior Q&A answers at previous webinars have stated, because the coding documents say that the mapping diagnosis description from an EHR may be used. Can you please clarify that?
Hi, this is Katie. Yep, and just to clarify, the earlier question stated that there was a mismatch in the documentation. So the code was present, but the diagnosis description was not consistent with the code description. So in that case, we would need additional medical record documentation to support the appropriate diagnosis. Coding alone within the medical record cannot be used to confirm that diagnosis. So if the code is present along with the matching description or any documentation in the medical record confirming that major depression or dysthymia, it would be appropriate to use. Thank you.
Great, thank you. All right, next, are blood pressure readings from home health visits by a nurse or doctor acceptable for the HTN measure?
Hi, this is Katie again. So blood pressure readings taken in-home by a qualified provider are allowed as long as there's medical record documentation supporting that the blood pressure was taken by a clinician. So if the blood pressure was taken by the patient at home or on a home monitoring device, that would not be allowed. And then to answer the second part of the question about a nurse, the blood pressure can be taken by any clinician the organization considers qualified and for whom the eligible clinician or group clinically manages. Thank you.
Great, thank you. All right, next, for population 2 of the PREV 13 measure, if a patient had an LDL greater than 190 in 2018, but has not had an encounter since, would their 2018 visit be included in the denominator for the 2020 reporting year?
So in the greater than or equal to 190, the information that goes along with that is that they have ever had a fasting or direct lab result of that value. So if they've had a lab result of greater than 190 in 2018 and you find them within your sample, it appears based on what limited information you've provided that that patient would be confirmed and you would look for statin therapy.
Okay, great, thank you. All right, next, if the questioner has documentation on fall risk screening done yes or no, would that be sufficient for meeting documentation requirement for CARE 2?
Hi, this is Olga from the PIMS team. For CARE 2, you would need to have documentation in the medical record of a fall risk screening that can include the patient's history of falls, a described fall, a note stating no falls, or an assessment of gait or balance during the measurement period. There is additional guidance provided on page 8 of the measure specification that indicates that the medical record must include documentation of screening performed.
Great, thank you. All right, as a reminder to everybody on the line, if you'd like to ask a question, you can do so by submitting it on your screen, or if you'd like to raise your hand, that's the green hand icon on your go-to menu, we'll unmute your line. All right, so your next question is just to re-clarify something that was provided earlier. As long as they have the code E78.00 or E78.01, and it states hypercholesterolemia with an abnormal LDL, can they take it without it stating the exact words familial or pure?
This is Deb, and I'm going to caveat this answer with it may be better if you go ahead and open up a ServiceNow case. The thing I want to make clear is that being able to use that code in conjunction with hypercholesterolemia documented is under the assumption that that code and the verbiage associated with that code includes pure or familial. What you don't want to do is confirm somebody for a measure and inadvertently hold the clinician accountable for statin therapy when it's a patient that should not be on statin therapy based on the denominator criteria. So what you're looking for, understanding that sometimes the medical records, a clinician may just document hypercholesterolemia, but you're also finding one of the appropriate codes for familial or pure cholesterolemia. That would be what you would want to use for confirmation. And again, if you have any question as to whether or not a particular patient should be confirmed because you're unable to tell by what you're seeing in the medical record, that would be something that we would not be able to answer. You would need to go back to the clinician or look further in the medical records to determine if you can confirm the patient. Because once you've confirmed that patient meets the denominator criteria, the expectation is that patient is on statin therapy or there is an appropriate reason why they're not based on the measure specification. Thank you.
Great, thank you. All right, we have another question from the phone line. So Leanne Schwartz, we're unmuting your line. And Leanne, you may go ahead. Leanne Schwartz, you may go ahead and ask your question. All right, so we'll go back to the questions box. It asks, what if blood pressure out of control is in an urgent care? Often in an urgent care setting, blood pressure is elevated due to stress, pain, or etc.
Hi, this is Katie from the PIMS team. And if you refer to the hypertension coding document, they do contain coding for urgent care settings. So in this case, if the most recent blood pressure is from an urgent care setting, you would need to use that. There's no denominator exception or exclusion available for the final blood pressure during the performance year that's documented. If it's elevated, that it may be excluded. So if it's in one of the settings included in the measure coding, you would need to use that blood pressure. Thank you.
Great, thank you. All right, next, can you have providers write in missing dates of service if there are any?
Hi, this is Katie from the PIMS team. So the data submission period is not to be used as a time to update or enter in missing information into the medical record. So in this instance, no, it's not appropriate to have clinicians go back into medical record documentation and fill in missing information. Thank you.
Okay, great, thank you. All right, next, going back to reporting requirements for this year, they would just like you to clarify why it's important to submit on or before March 20th of this year, please.
Hi,
Can you repeat the question? Oh, sorry. Go ahead, Katie.
That's okay. So if this is related to the CMS Approved Reason request, and we're just encouraging folks to submit prior to Friday, March 20th, in order to allow time for these cases to be processed. In some instances, additional information might be needed from the organization submitting the request. And it does take a bit of time for these requests to go through full review cycle, depending on the information provided. So we're encouraging folks to submit sooner to ensure that your request is processed prior to close of submission. Thank you.
Okay, great, thank you for that. All right, next question asks, if we have records that we cannot access, what do we mark and what do we do then? Do we just have to gain 248 more consecutive charts?
Hi, this is Aslam. I can answer this question from the system standpoint. If you have a valid reason to skip a patient, then you can complete the next ranked beneficiary, which would be 249, and so on, so that you can meet the 248 minimum reporting requirement. Thank you.
Great, thank you. All right, next, should SNOMED codes be used to confirm diagnoses the same way that ICD-9 codes are used?
So this is Deb. I would say we don't necessarily use the coding to confirm diagnosis unless you're using that coding in combination with medical record documentation. So if you're finding SNOMED coding and verbiage and you're also finding medical record documentation and you're combining those two and it meets what the measure is requiring for the denominator, then that would be appropriate. But coding alone is not acceptable for any of the measures. It's really a understanding that there are times that based on the way your systems are set up, that you're able to see the coding and the verbiage associated with that coding, and you're able to see documentation in the medical record, and the combination of those two things is enough for you to confirm whatever it is that you're trying to confirm within the measure you're referring to.
Okay, great, thank you. All right, your next question asks, for PREV-12 depression screening and follow-up, can the presence of a negative screen HCPCS G8510 in the patient's chart meet the negative screen documentation?
Hi, this is Katie. So as in any case, coding alone cannot be used as sufficient documentation. So if your medical record only contains a code, you would need additional information within your medical record outlining that the screen was negative. Thank you.
Okay, thanks. On a similar note, based on what was previously said about coding, and the word depression along with a proper major depression code in the chart, would that be acceptable to confirm a patient in mental health?
This is Deb. I'm going to say yes, but I'm also going to ask Katie because she typically answers those MH1 questions. Katie, if you have, kind of the verbiage that we typically use, I know there's a specific code that we say if you have that major depression code, and yet you can also find documentation of depression, the fact that you can combine those two things together is enough to confirm. Do you have anything to add to that?
No, nothing additional to add. Yes, there is reference within the measure specification on how to appropriately confirm or what documentation meets the requirements for confirming a diagnosis. And I can continue researching. If we can come back to this question, I can cite a page number for those listening.
Okay, thanks. We'll come back to that. Okay, next question. Is a patient excluded from any measure if they pass away during the measurement period?
So this is Deb. I would point you to the patient confirmation section in any of the measure specifications for the web interface. If a patient is deceased, that is one of the not qualified for sample reasons. If they're deceased and you don't know the date, you do select this option if the patient died during the measurement period. If you don't know the date they were not qualified for the sample, the guidance also provides information that you would put in 12/31/2019. So again, it is the patient confirmation section of all of the measure specifications for the web interface.
All right, great. Again, just a general plug for anybody on the line. If you'd like to ask a question over the phone line, please go ahead and raise your hands, which actually just happened. So Michael Levant, we will go ahead and unmute your line. All right, Michael, you may go ahead.
Hi, thanks. This question is in regards to PREV-12. So under the measurement specs, it states that the screening, that the results must be reviewed and verified and documented by the eligible professional in the medical record on the date of the encounter. What is the definition of an eligible professional? Does that mean an eligible professional who can actually do the screening, or does that mean it's a physician or an NP? And then I have a second part to that question.
Hi, this is Katie from the PIMS team. So for purposes of the web interface submission, the clinician can be considered, it's anyone the organization considers qualified and for whom the eligible clinician or group clinically manages. So to elaborate, there's not a strict definition of who can perform the screening and do the follow-up. It just needs to be somebody for which your organization considers qualified and manages.
Okay, great. Thank you for that. All right, so just circling back to the MH1 question, based on what Deb was saying about coding and the word depression along with a proper major depression code in the chart be acceptable to confirm a patient in mental health?
Hi, yep, this is Katie. So that additional guidance is present on page 9 of the MH1 measure specification, and it is under the denominator guidance. So in order to confirm a diagnosis of major depression or dysthymia, you can use any of the following methods, which includes a diagnosis on the encounter or problem list, regardless of the vendor-assigned description of the code, or the words major depression, major depressive disorder, dysthymia, dysthymic disorder, pervasive depressive disorder, on progress notes or problem lists. So additionally, in paper records, the description depression can be used with the option to confirm by billing code. So again, that is available on page 9 of the MH1 measure specification.
All right, thank you. All right, your next question concerns PREV 13. It asks, we have a patient in our PREV 13 sample that meets the intent of the measure but doesn't qualify for the third population as a diabetic because her LDL values are all controlled within the 2-year look back. But more than likely, if she were to go off the statin medication, she would not be in control. So to this inquirer, they believe that they shouldn't be skipping this patient due to being unable to confirm the denominator as the patient is being compliant with the medication. So can you please advise?
Yes. So the thing is I'm assuming when you say that they're eligible, that you think that based on your medical record review that they meet the denominator criteria for either patient population 1, 2, or 3. If that's the case, I would recommend either you add some clarifying information within the question box or open up a QualityNet help desk ticket and we can work through that. However, if you're saying you believe they meet the denominator criteria for population number 3 because of their diagnosis of diabetes, but they do not have an LDL-C of 70 to 189 during the measurement period or 2 years prior to the beginning of the measurement period, then they in fact do not meet the criteria and they should be skipped. But please keep in mind that the CMS Web Interface measures are not intended for necessarily for the clinician to do something in their practice any differently. So if that patient is on a statin therapy because that's what a clinician intends, then we are not in any way speaking to that. We're just talking about the measure itself and the quality action that it's measuring for a very specific patient population. And so again, if this particular patient you're seeing does not meet the patient population based on the measure criteria for population 1, 2, or 3, then the information on that particular patient is just not intended to be included. It doesn't speak to whether or not that patient should be on a statin or not.
Okay, thank you for that. All right, next question concerns PREV 7. They ask if we have a note during an office visit between August 1st of 2018 and October 1st of 2018 that the patient reported receiving the flu shot, but the patient doesn't specify when exactly they received the flu shot. Is that acceptable to pass the measure?
Hi, this is Jamie. Thanks for the question. In order to pass that measure, you're going to need to have medical documentation that The flu shot was actually administered between August 1st and March 31st to meet the parameters as defined by the measure specification. Thank you.
Great, thanks. All right, another one. One on hypertension asks if we have documentation of hypertension which maps back to 110 essential hypertension, is this valid to confirm the patient? Likewise, if we see I-10 and hypertension, may we confirm the patient?
Hi, so this is Katie again. Just to kind of reiterate what Deb said, if you have if a code is present and you have medical record documentation supporting the appropriate diagnosis, it would be appropriate to use. What we're really saying is you just need to have supporting documentation to ensure that the diagnosis is appropriate, whether that's a combination of coding and medical record documentation. Your organization just needs to confirm that it meets the definition within the measure specification. So in this case, if you have a description of hypertension, but a code available that supports essential hypertension for that patient, it would be appropriate to confirm. That's also keeping in mind that the diagnosis is within the appropriate time frame for the measure, which is within the first 6 months of the measurement period, or any time prior to the measurement period, but does not end before the start of the measurement period. Thank you.
Great, thank you. All right, and it looks like your last question asks, again, about Prov 7. Can you please help them understand the difference between the measure spec stating that October 1st, 2018 to March 31st, 2019 for an office visit with a flu shot versus August 1st, 2018 to March 31st, 2019 for a patient-reported flu shot?
Hi, thanks for asking this question. There's a really important delineation between the two time frames. For that October 1st through March 31st, that time frame really is speaking to denominator eligibility. And for the web interface, what I would suggest is going out and taking a look at those sampling documents that are on the resource library, just to ensure that you can see how we actually derive that patient sample. And then the date, the next time frame that's within this question, the August 1st through March 31st, that really is attesting to that time frame where you can look and see if the patient was administered the flu shot. And so that speaks really truly to that numerator piece, and when you can identify if the patient actually met performance for the measure. So two very different time frames speaking to two very different aspects of the measure itself. So please submit a ServiceNow ticket if you need any more assistance. Thanks.
All right, thanks. One more question before I pass back to you, Reina. It asks if there is a hypertension diagnosis in 2016 and no mention of it after that or about it being resolved, would that count the patient in the hypertension denominator?
Hey, this is Katie. So in this case, it would be up to your organization to determine if that diagnosis should be confirmed. So you would need to review the medical record documentation and ensure that the diagnosis did not end before the start of the measurement period. I can't speak specifically to this instance because it is up to your organization to ensure whether or not that patient should be confirmed. Thank you.
All right, thank you for that. So it looks like that's all we have for the Q&A today. So Reina, I'll pass it back to you to close out.
Okay. Thank you all for joining us today. The slide deck, recording, and transcript from today's call will be available on the QPP webinar library in the next 2 weeks. As a reminder, our next support call is scheduled for next Wednesday, March 18th from 1 to 2 p.m. Eastern Daylight Time. And during this webinar, we will cover frequently asked measure questions about confirming a diagnosis, the DM2, hemoglobin A1C, poor control, IMH1, depression remission at 12 months, and PREV12, screening for depression and follow-up. We hope you'll join us, and thank you for joining us today.